Good afternoon, students. We are today talking about mass in the left hypochondrium. And before we proceed, I always have this slide because whatever said and done, one has to realize that hypochondriums are the smallest segments. So hypochondrium is the smallest part in the abdomen. So there could be a possibility of the masses from the neighboring, like from epigastrium, one can go there. The kidneys, for example, will come here somewhere. So these are the smallest quadrants, but we have to make our practice to see that once you finish the examination of all these usual about the mass, remember spine system, obviously female, supraclavicular lymph node, and when I say swelling in the loin, when I say this only. So this should be our completion at the end of your clinical examination. You no doubt you start a superficial palpation there, and this is a superficial palpation is done initially because sometimes you don't know, some tender area may be there, so you would like to avoid the tender area. When you have some fluid, portal hypertension, for example, there may be a little difficulty in even feeling the spleen, so you may have to do a dipping method so as to get the spleen as well as the liver. And last time I told you, any tender mass in the abdomen, you know, the ball of your palm as well as the both hands, you compress the lower xiphisternal area, so as patient will breathe more from the abdomen, so that your abdominal palpation becomes method. This is to be done only if there is guarding and rigidity. So this is the small introduction for the splenic, whatever the left hypochondric mass. Last time I have told you, whenever you are given a mass abdomen in the PG examination, whichever quadrant for that matter, just think about at least spend some 2 minutes to think what structures will come there before you really start examining and getting the history. Everyone knows the spleen is the most hot favorite organ which comes in the left hypochondrium. So it is very easy for me. I will pass my MS exam. That's fine. But also keep it in mind, you are a postgraduate. So you need to know some other organs which I just now told you. Because splenic hilum, lower pole of the spleen, you would have probably assisted open splenectomy or laparoscopic splenectomy. So think for some time, oh, I think that day the colonic mass, colon was separated from the spleen, lower end. Oh, near the hilum, the tail will come. So what I'm trying to tell is, just these are some of the last moment, you know, sudden think about these organs, so that you know, I should think of splenic flexure of the colon. I should think of tail of the pancreas. If there's nothing is there, I may have to consider retroperitoneum, and renal, of course, and adrenal will come. So after considering that, I have thought of 5 anatomical structures. Now, after talking about 5, now start thinking about what disease will arise from the spleen. Obviously, today's concentration is more on the spleen. We'll come to that. Splenic flexure of the colon, for all practical purposes, let us consider only one pathology, and that is carcinoma of the colon. Let us not consider tuberculosis. I have seen some students answering tuberculosis for splenic flexure area mass. So you know that tuberculosis is not all that common there. Let us not talk about that. So when you come to the splenic flexure, you think of only carcinoma colon. Then we have tail of the pancreas. We'll come to that. Today I will not talk more about this because my next class, the time permits, it will be on Monday. It will be on a lumbar mass. So that time I will give all the details about this. Today I've just touched upon 2 slides. And I have told you last time, when you take the history, none of the symptoms are of any system. Upper GI, lower GI, hepatobiliary, pancreas, think about retroperitoneal, right? So this is how we start thinking about probably what may be my case. So we'll come to your case now. Think that there is a mass in the left hypochondrium. Patient has dull aching continuous pain, means obviously it's a solid organ enlargement. That should be spleen, because if it's a hollow viscous means you will have more of a colicky pain. I have written here, you see, recurrent attacks of here, sorry, several severe colicky pain suggests large bowel obstruction. Especially splenic flexure masses are known for producing large bowel obstruction. They also will have alternate some kind of altered bowel habits, rather more increasing constipation. Yes, loss of weight, loss of appetite. Go back to this symptom. You have one patient who has got fever, high degree, coming from the malarial belt, or it could be chronic, malarial spleens, we call it as, you heard of the tropical splenomegaly. I will not talk more about that part today. We have another patient who says, young patient said, I admitted 3-4 times in the hospital last 5 years, and every time I get some little abdominal pain, I get some mild yellow discoloration. See that? You got the clue here. Most probably this is a hemolytic anemia. So you know how to look for splenomegaly, anemia, jaundice. That's a triad of hereditary spherocytosis or hemolytic anemia. So just take carefully type of the pain, fever, abdominal pain and admissions, attacks of hematemesis and melena. You know that one another important condition where postgraduates can encounter is a palpable spleen, is the portal hypertension, and more of a extrahepatic, also called as prehepatic. So it's no cirrhosis here. It's portal vein thrombosis or splenic vein thrombosis. So these are the patients who can present with hematemesis or melena. So when you have a left hypochondric mass, this is the history which you will going to take. So again, if there's a hematuria and flank pain, you think of a renal cell carcinoma here. Certain belts of pancreatitis, acute and chronic pancreatitis, recurrent pain radiating to the back. One can have a pseudocyst arising from the tail of the pancreas. I have told you sometimes back, tail of the pancreas is attached to the spleen. So you should also think, is there a lesion arising from the pancreas? I have written here, these are for the pheochromocytoma, alcohol consumption, smoking, diabetes, hypertension. These may give you certain clue whether it's a cirrhosis liver. Smoking here, known for a cancer of the pancreas. Patient has got diabetes recently. Oh, is it a chronic pancreatitis with pseudocyst now? Patient is hypertensive. Is it RCC, renal cell carcinoma, or renal adrenal mass, etc. So you take all these symptoms and then you start thinking and analyze. I already mentioned to you a few of the points here, that how you analyze the history. I have my patient with the fever and mass. So is it a malaria, or is it that we have got other conditions which I already mentioned to you? So if the patient has got features of colonic features, as I mentioned to you, increasing constipation, obstruction, think of, is it I am dealing with the carcinoma of the colon. So history taking is not difficult, but you need to apply starting from the age of the patient and go with the symptoms. We have already mentioned this last classes that past family personal together I mentioned here. I mentioned to young girl, recurrent admissions, she will go for a hemolytic anemia. This is for chronic pancreatitis. Patient has been admitted to the hospital many times for blood transfusion for anemia. Young patient, I have seen this, and it was a case of extrahepatic portal hypertension with the varices, with the bleeding. People thought only alcoholics will develop portal hypertension. So she is a girl, and that was a case of portal hypertension. So whether the patient has been put on any drugs, especially to reduce the portal pressure, propranolol, etc. Right? So you take the past history, family history, personal history. This I think I will not go in further detail. So you are given now patient, you have got now to examine now. You look pallor, so you are noted now. My patient has anemia. So I know I need to correlate at the end. When I give a diagnosis, anemia, splenomegaly, oh, so is it something related to the spleen? This is how you think. Lemon yellow, hemolytic, evidence of chronic liver disease. Chronic liver disease refer to cirrhosis of the liver. This is what chronic liver disease here. Palmar erythema, pedal edema. When I took the right hypochondric mass, I have discussed with you. Patient is ill. Patient has got fever. Hemolytic crisis. Patient has got dehydration. Patient is obstruction. Abdomen is distended. So these are the indirect hints for you. So look for dilated veins. We have mentioned to you. Caput medusae. Definitely, if your case is a splenomegaly, they will definitely ask you portosystemic collaterals. This is the one area where students fumble to mention what is portal and what is tributary, what is systemic. Portal branches of the left gastric vein here, and the systemic is branches of the superficial and inferior epigastric vein. This is the veins which run in the falciform ligament or umbilical veins. So that's why you don't find much caput medusae, because by the time the patient is born, usually the veins are obliterated. So look for any dilated veins in your case. I have just brought this to show you. You don't get this in this case, but just look at the comparison. You should be carefully watch what we call as eagle's eye to see the faint jaundice here. Faint jaundice here. It was an interesting case of hemolytic anemia. So this is a deep greenish hue here. It's more of a biliverdin here, and this is the faint hemolytic anemia. So this is how you start examining the patient. I don't want postgraduates to straight away mention pickle. What is the relevance of cyanosis in your case? Your case is a splenomegaly, or your case is obstructive jaundice. What is the relevance of mentioning clubbing in your case in a 20-year girl? So as well, I will give more importance if you say, my case is splenomegaly, sir. I have looked carefully for lymph nodes in the neck. Now remember, we'll come back to the supraclavicular later, but just to keep you an idea, what is the significance? In your case, you have to talk. We have got a mass in the left hypochondrium. If the examiner asks you, you got a supraclavicular node, don't say no, carcinoma stomach. Your case is mass in the left hypochondrium, so carcinoma pancreas or carcinoma colon. Okay, this is just to give another example. You got a splenomegaly with a neck nodal mass, typically the big nodal mass. Obviously, that is a Hodgkin's lymphoma. And your case is a splenomegaly, and you have got the external Walde's ring involvement like here. You have got the submandibular, preauricular, postauricular, etc. Oh, so this could be a non-Hodgkin's lymphoma. I hope it's clear now. So always you should talk to your patient. Why there is anemia in your patient? If you say, so there's a splenomegaly, so this is what is explanation. Why there is a lymph node? In my case, I am entertaining 3 diagnoses I have in mind. So this lymph node could be related to this. So rather than talking about cyanosis and clubbing, they have no relevance at all. You have a patient who has got a thyrotoxicosis, etc. You know how to explain the pretibial myxedema with the thyroid acropathy. Then yes, there is a role for a clubbing. I hope it's clear. So you are now kept in mind your case. You have taken the history, and you are now started examining, and you are doing the inspection now. You like any other inspection, is it not? I have again mentioned to you very many times, when the abdomen is distended, better to say fullness is seen rather than mass. Remember, always fullness has no dimension. If you commit and say there is a mass, examiners expect you to talk about location, size, shape, surface, all that details. On inspection, if you are not able to make out, your case is a portal hypertension, there is some ascites, there is some bowel obstruction, whatever it is. So then better you say fullness is seen in the whatever the hypochondrium, etc. I hope it's clear. If you have any doubts, I'll give you some time later. So now ask the patient one important thing. Ask him to take a deep inspiration. Does he get the pain? This is an important point. One clue for you. When he takes a deep inspiration, he says, yes, I get some catch-like thing. Oh, that means you are dealing with the splenic mass. Most probably. That means it is unlikely to be other conditions which I mentioned. So if it is spleen, is there any infarction? All of you know sickle cell anemia, hemolytic process, hemolytic crisis can take place, some infarction can take place, so they can have perisplenitis causing pain. So you should know how to explain your findings. This could be perisplenitis causing pain. Right. You are concentrating on the left hypochondrium. Start examination from the right leg fossa, because all of you know, so that spleen enlarges generally towards the right leg fossa. So you start examining from the right leg fossa and go towards the left leg fossa. And like any other mass now, your exam case, there's only finding is splenomegaly. There are two ways of looking at the problem. I accept both, but I have seen in vast majority, your case is only splenomegaly. Don't say spleen, because the suspense is gone. That's what the examiners will comment. For me, it doesn't matter. For me, even if you say there's a mass palpable, which say majority, most of the examiner says you better say mass palpable. Okay, take it that way. So location, all the details, I don't have to repeat, no, all these things with those minimum 10 points: size, shape, surface, border, consistency, mobility, fixity, plane of the swelling, and of course, upper abdominal mass, upper border or finger insinuation is important. Lower abdominal mass, lower border is important. This is how you know, especially in females, so that you know you are ruling out a pelvic mass, right? So I think there may be 5 points or 6 or 7 more points. Just to remember, we are only repeating. Spleen, typical site is a left hypochondrium. But remember, a common mistake done, don't examine the spleen under the costal margin and say spleen is palpable. No, spleen is not palpable under the costal margin. Spleen is more lateral structure. More lateral structure. Common mistake is to feel it in the costal margin area. No, that is wrong. Go a little away. All right. Yes, enlargement is towards the umbilical region or right iliac fossa. Spleen moves very, very freely with respiration. All of you know the typical 1, 3, 5, 7, 9, 11, the typical, the formula for the spleen, I think you know. It is under cover of the ribs. So obviously it is coming towards the right iliac fossa. I have seen very often it's not a great mistake. People, the notch is present towards the enlarging anterior end of the superior border. Please remember this small point here. Very often people say it is the anterior border has got the notch, but anatomically, if you see, spleen has got only 3 distinct borders: superior, inferior, and something like intermediate. And it is that superior border of the spleen has got the notch at the anterior end. So it's a very small difference. As long as you appreciate a notch is palpable, that means it is very, very characteristic of the splenic masses. It is fine. Some examiners may ask you where is this felt. Very often you mistake you do is anterior surface, anterior border. There is no anterior surface for the spleen. You think as a visceral surface and a diaphragmatic surface. Is it clear? Diaphragmatic surface is the one which is in contact with the diaphragm. Visceral is the typically all viscerae, whether it's the colon, tail of the pancreas, they're all attached there. And the borders, these are the 3 borders. So it is the anterior end of the superior border has got the notch, and the notch can be absent also. Notch can be absent. It depends upon the enlargement, depends upon some congenital anomalies is possible here, some kind of a bosulated spleens, so nodular spleens, lobulations, all are possible. Anyway, enlarging spleen, you can't get the upper border. So to say that finger insinuation is not possible, and classically it is dull. Like a liver is dull, spleen is dull, and that dullness has to continue with this mass to know that you are having the spleen. So I don't think you have any questions now at this stage. So please remember to use this word if possible. It is the superior border of the spleen has got a notch at the anterior end, right? Yes. So now kidney. I mentioned to you Next class will be on lumbar mass, but again enlargement is more superior inferiorly, and this is the characteristic explanations which we'll give next class. And upper border cannot be appreciated because you know that kidney enlarges, it is also under the ribs, under the ribs. So obviously it is difficult to get the upper border in a upper polar mass, right? Now, so you have felt the mass. If there's a tender mass, then you should try to analyze. I have written here kidney. We don't keep you pyonephrosis or perinephric abscess, so you just get rid of that from your mind. This is only for completion's sake. You find a tender spleen, or is it that is it a malaria, or is it some hemolytic crisis is there? Tail of the pancreas means chronic pancreatitis. Carcinomas and adrenal masses are usually non-tender. So each physical sign has to be correlated with your diagnosis, what you are having in the mind. This is what I am trying to tell you. As soon as you put a hand, you get the mass. Then one thing I can assure you, these two are unlikely. As soon as you put a hand, you got the mass, means so that is spleen. Or maybe a retroperitoneal mass which has come very large. With a gentle palpation, I got it. Or is it a kidney? Splenic flexure is the deepest portion of the bowel. Please remember this, large intestine. So splenic flexure mass is very difficult to feel. It is deeply felt unless it is very large. So when you get a mass which is easily felt means, I think these two look like ruled out. Probably it is spleen or kidney, etc. Even though spleen is the main organ here which moves with the respiration, but you see all are attached. Renal system I have explained to you other day, because of Gerota's fascia which is attached above to the diaphragm, it moves with the respiration. Tail of the pancreas is attached. Tail of the pancreas is attached to the spleen and moves with respiration. So you can also ask me the same question, splenic flexure of the colon. Invariably the malignancy arises from the splenic flexure. Carcinomas are infiltrative. By the time a mass forms, it hardly moves with the respiration. So a mass which moves very freely is the spleen, followed by kidney, etc. Right. So now you are done the tenderness. Then you are going to ask for all this large size, small size, surface. Polycystic kidney is the one which is having a bosselated surface. Again, next class. Surface of the spleen in most of the areas of the splenomegaly, we find it's a smooth surface. Maybe a hematological malignancies, there may be some irregularity. Small size carcinoma, splenic flexure, or tail of the pancreas. Irregular or nodular surface is for typical carcinoma in general. Whether it's a carcinoma gallbladder, carcinoma stomach, carcinoma colon, this is typical of a irregular nodular surface in carcinoma. You talk about consistency. Yes, majority of the spleens, whatever we feel, they are firm in consistency. Even if the cystic tumors which appear from the tail of the pancreas, they may be having cyst, but they are tensely cystic, they all feel firm. Last class I have mentioned intra-abdominal cystic swelling. Don't say that I have elicited fluctuation, no, right? So malignancies are typically hard in consistency. So like a liver, because liver is coming from under the costal margin, spleen also is coming under the costal margin. So you can't hold the spleen and move freely. That is what I mean by the word intrinsic mobility. I hope it's clear because it's coming from the bony cake down. So pancreatic cystadenomas will have some amount of mobility, what has been called as tree top, and of course enlarged kidneys usually may have a limited mobility because it's again under the lower cages. But as I mentioned to you, every rule or every law has got an exception. A renal tumor arising from the lower pole of the kidney may show some amount of mobility. Plain, I don't think you have to do knee elbow test again here. Splenic mass moves with the respiration. Straight away you know that it's intraperitoneal. You have felt the renal mass in the lumbar region, and which mass does not move the respiration are usually retroperitoneal masses, right? So it's very easy to decide plane of the swelling in these patients. You have done examination, you have got the spleen, look for the liver, because you are dealing maybe with the lymphoma, maybe leukemia. So you look for the percussion, auscultation, shifting dullness for fluid, and you auscultate for bruit, and auscultation over the spleen for perisplenitis. This is some kind of a rub, not in a patient it is for a especially infarction of the spleen cases. Your case is a carcinoma of the splenic flexion. Now is the time for you to look for a dilated colon, tympanitic cecum, indication of a obstruction. So look for liver metastasis, supraclavicular node, and of course rectal examination for Blummer shelf. So with this, before we come to the clinical examination, which is complete, spleen being a reticuloendothelial organ, whether it's the malaria, whether it's hemolytic anemia, whether it's a portal hypertension, doesn't matter. You have to make a policy to look into liver, bony tenderness, is there a sternal tenderness or iliacus tenderness, any cervical lymph nodes, oral cavity, especially non-Hodgkin's lymphomas, and of course any bony metastasis is present, spine examination, all to be done. I will stop at this stage for 2 or 3 questions or 4 questions. For the clinical examination, what we have done up to now for the splenic masses, the details. In particular about each organ we are going to start now. If you have any question to ask, what other examination to be done for the left hypochondrium, please ask.
Sir, I have one doubt, sir.
Yeah, please.
Sir, how will you differentiate between a splenic mass and splenomegaly?
What do you, I have not understood your question. The spleen to be palpable, it should be at least 2.5 times enlarged. So what you are trying to tell is splenomegaly can be detected by ultrasound even when spleen is not palpable. So splenic mass, when you say spleen is palpable, okay. Is that one you wanted to answer, or what answer you have?
Yes, sir. And then like for on the reverse, on the right side, how do you differentiate a liver mass from a hepatomegaly?
What is that?
How do you differentiate a liver mass from hepatomegaly, sir?
Oh,
I mean,
liver. So you I think emphysema patient. That's why you do that, no? Starting from above, liver span you do, no? When
yes,
we say
sir.
liver mass means we are clinically palpating the mass. Mass is a new mass, new lesion arising from a organ, whereas enlargement is liver can be pushed down. Is it clear?
Sir.
Sir wants to say, sir, Prakash sir.
Yeah, the answer question that boy, how to differentiate hepatomegaly with the liver mass. The consistency changes and abnormality of the liver, the noduloid may be there, the undulations may be there, umbilications may be there, uneven surface may be there. There's about a noduloid or liver masses. Whereas simple hepatomegaly will maintain its uniformity around round border and normal consistency. That's how we differentiate between hepatomegaly to liver masses. That's what we wanted to probably. Coming to spleen here, like rightly sir said, it's about 2 to 4 times its normal size to become its clinically palpable. So simply don't know, PhD should not say there's no splenomegaly. They can only say clinically spleen is not palpable. That's it.
Yeah. Any other questions?
So
yes.
Various methods of palpation of spleen.
Sorry?
Various methods for palpation of spleen.
Yeah. Just we'll come to that. I think you people are you might have studied it medicine, but individually I'll just tell you 1 or 2 methods very soon. Any other thing to question is there now, up to now?
Sir, hello,
Yeah.
sir.
Yeah.
Sir, in sickle cell anemia, we are taught that there will be autosplenectomy.
Yeah,
Will there be?
I'm not trying to see, I'm not going to discuss with you in detail about the lot of those hematological conditions. So initial part, there could be a splenic infarction. Otherwise, it's a usually autosplenectomy. Okay. Whereas a hereditary spherocytosis, spleen will be enlarged. Okay.
Okay, sir.
Right.
Thank you, sir.
Yes.
The PG should know at this stage why there is splenic notch is present in the splenic swellings. Number one, every PG should know in the examination, and they should also know why the spleen enlarges towards the right iliac fossa, whereas the liver towards left iliac fossa. Every PG should be able to answer these questions in the examination.
So with this background, we will go to a splenic mass. So as somebody asked that question, how will you examine? Enlarged spleen can be examined in a simple supine position itself, no problem. But if you have, as I mentioned to you, the spleen should not be felt under the costal margin. You should go peripherally under the 10th rib. So if that is the situation, a case of a mild enlargement, you may have to put your stand on the, you have to stand on the left side of the patient, put your one hand under the costal margin, and with the right hand, you should be able to insinuate your fingers and try to feel it under the 10th rib. So this is an important thing. You asked a question, no? So you can start from the right iliac fossa, or standing on the right side of the patient. You can stand on the left side of the patient and examine the patient also. Hutchison grades it as 3 centimeters, 7 centimeter, and above 7. So that's how you say that mild, moderate, and the 3 grades are there. Okay, severely enlarged, mild, moderate. All right. So this is how you grade the spleen. Now, when we were students, usually wherever I have studied, they never asked me these questions. But nowadays, some people ask this: what is Traube space? The next picture will give you. It's all given in the books. You would have all read in medicine. Just to keep you informed, this is the Traube space, right? You see, this is the semilunar area. This is a lung here, and this is the costal margin. This is the anti-axillary line. This is from the internet. You'll get this in all area. Normally, there's a left lobe of the liver comes there, and this is the stomach here. Stomach will give a resonant note. So when the spleen is enlarged, maybe you are even not even palpating here. If you percuss in the Traube space, means lower intercostal spaces, not 5, 6, 7, down, 8, 9, 10. This resonance of the stomach is obliterated, what has been called as a Traube space. In the last class, when we took, somebody asked this question on what is Castle sign. See, these are all not very, very important. Lot of criticism is there for this Castle sign also. At the tip of this Traube space somewhere here, there's a small space called as a Castle space, which if you take a deep inspiration, when the lung expands, that resonance otherwise of the stomach gets obliterated. So that is called as Castle sign positive. So these are, somebody asked me the questions, no? So mild 3 centimeter, moderate 7, and large is 11. And when the spleen is not even clinically palpable but still enlarged, is there a method to find out? Maybe that is a time you can mention about Traube space and this Castle sign. So now, what are the important surgical masses of interest for a surgeon like us? One of the important mass we are interested, your long case can be a portal hypertension, and usually we refer to extrahepatic portal hypertension here. Hereditary spherocytosis, another condition. These three I have kept it only for the sake of to be kept in mind, because lymphoma of the spleen alone, usually it is not there either. It's lymph node with the liver. Chronic myeloid leukemia, in our institution we don't keep it because these are all for medical, and other conditions, rare condition like splenic cyst, hemangioma, these are for our sake. If you go to the medicine, there may be a 25 differential diagnosis, including glycogen storage disorders, etc. Toxoplasmosis, including that splenomegaly of Basu. So there are so many tropical splenomegaly. So I'll be concentrating only on few of these so that we can proceed. So when we talk about extrahepatic portal hepatitis, see your patient. Your patient is, let us say, 25-year-old. You got the spleen, which is moderate size, smooth and firm in consistency, and look at that last important sentence. Liver function is normal. So liver function is normal. Ascites, jaundice, other features of cirrhosis are absent. So most probably it's an extrahepatic portal hypertension. Either it's a portal vein thrombosis or non-cirrhotic portal fibrosis or splenic vein thrombosis. Your case is splenomegaly. Patient might have been admitted for hematemesis. So give a diagnosis of extrahepatic portal hypertension, right? So this is one important condition. So carefully look here. Spleen has got a notch we have mentioned. Pseudocyst means round. Ballatability means kidney mass. And every rule has got exception. Now, clinical differences of portal hypertension. I will not explain this full. Just for you people are to know, in cirrhosis of the liver, this is the classical your medical case. Spleen is, say that, palpable. But I am talking about these two here. Look here. This is extrahepatic. This is non-cirrhotic portal fibrosis. Look at the splenomegaly. It's written in red here. I will not talk about Burchiari. I will not talk about cirrhosis. You concentrate on these three, third and fourth column. Look at the age of the patient. Look at the variceal bleed. Look at the ascites. Usually it is not there. Pedal edema is not there. Hepatic encephalopathy is not there. So your finding is only spleen and the liver may be palpable. See here it is normal, whereas extrahepatic portal fibrosis, it is firm. So you concentrate mainly on these two conditions. When you are in a surgical ward, when you give a diagnosis of a splenomegaly, am I dealing with extrahepatic portal hypertension? If so, what I have got? Or am I dealing with non-cirrhotic portal fibrosis? What is this list which I have got? I hope with these things, simple things will help you. Now, am I dealing with a hemolytic anemia? How is that? So, younger patient, recurrent abdominal pain, faint jaundice, moderate splenomegaly, anemia. I already mentioned to you triad of hereditary spirocytosis, that is the splenomegaly, anemia, jaundice. This is the faint jaundice, lemon yellow in color, and this is the moderate size splenomegaly, and this is your case. See that spleen? You are going to describe the spleen, all that easy, smooth with respiration, is a non-tender. Patient has got anemia and jaundice. Liver is usually not palpable, no other features. So you say this is a diagnosis is probably hereditary spirocytosis or hemolytic disorder. Now another one or two I have brought it over here, this discussion, because as surgeons we also deal with what is called autoimmune hemolytic anemias. Here this important thing is to check for the hemoglobin IgG, and they will ask you, will you do straight away splenectomy? Your answer should be, they are very responsive to steroids. So please remember, you try the steroids, taper it for 3 months. Still not responding, you have to have an answer, azathioprine or cyclophosphamide. Still not, you want to get more marks, rituximab is indicated as initial therapy in steroid unresponsive cases and refractory cases. So if your case is autoimmune hemolytic anemia, your patient is not responding to steroids, you have tried these drugs, tried this also, not responding, then in the examination, your answer should be splenectomy. Please remember, I am discussing more of clinical examination in this rather than treatment of each condition. It is impossible to complete treatment of each condition. So splenectomy in autoimmune hemolytic anemia has shown similar efficacy as steroids, but must be considered only after trial of above mentioned therapy. Again, the another condition where surgeon is encountering is ITP. All of you know. Here also again the treatment part, I think you read medicine books. Again here steroids, first line of treatment, and the spleen is mildly enlarged. If at all they ask you, When do you get a very just 2 fingers below the costal margin, etc.? That is the usual in ITP cases. Hemolytic anemia of hereditary spherocytosis, it can go up to the moderate size, whereas chronic myeloid leukemia, you will get a much bigger spleen, right? So second line of therapy for, again we are talking about ITP, again rituximab is there versus splenectomy. So just get yourself prepared to read, especially when you open the splenic chapter. What I have seen is, because invariably surgeons only ask a trauma, blunt abdominal trauma and spleen, there's a tendency to not to read about the medical causes, but read at least medical causes of surgeon's interest. You should read for spleen, the spleen chapter, right? So that's what it is the case. Faint jaundice, enlarged spleen, and the spleen at surgery. This is the purpura patient. This is, I think, we may ask you this question. What is Hess tourniquet test? At least there should be a 20 petike in a circle of 3 centimeter diameter in the cubital fossa. That means then only you say that there is a probably bleeding time is prolonged in purpura, and clotting and prothrombin time are normal. Right? I have written here the, as I mentioned to you, other conditions. Sometimes you get a huge spleen. I got another huge spleen patient at such a discomfort. Hardly any drugs were there. It's about 15 years back. And that turned out to be hairy cell leukemia. So whenever you have a massive splenomegaly as a surgeon, apart from the myelofibrosis, you have to consider these 3 in your exam. Whether I am dealing with the lymphoma, chronic myeloid leukemia, or is it a hairy cell leukemia. But today, remember, in all this condition, splenectomy is rarely indicated, because splenectomy per se is not the primary answer. There is, you have to treat these diseases. Then only you may be able to say splenectomy as a last resort for a discomfort in this patient. Of course, definitely, if the patient has got hypersplenism, that will be always a definite indication for splenectomy. This was a size of the hairy cell leukemia spleen which I removed, and one of my friend initially asked a question about sickle cell anemia. It was a long back. This patient presented with the gallstones. It was an open cholecystectomy that time. We opened the patient for cholecystectomy and we removed, and just for a casual interest, ultrasound said the very spleen is enlarged. Maybe that was the mistake of the sonologist that time also. Just put my hand on the left side. As I was trying to feel something, just it came in my hand, and that was the spleen. And this was the typical infarcted spleen, because somebody asked this question. This is a typical auto-infarction. Such spleens are also called as some kind of a nugget spleens, right? So rarely splenic cyst, dermoid cyst, hemangiomas, tuberculosis, splenic hydatid, all have been mentioned for the sake of completion. But I repeat, you have a mild, moderate, and large spleens here. ITP gives the mild here. Moderate spleens are portal hypertension, very important. Extrahepatic I mentioned to you. Hereditary spherocytosis. Yes, then comes all other diagnosis of interest, depends upon your case. I will take 1 or 2 questions and stop at this stage related to spleen. So if any students want to ask any questions, please ask. I'm only told you surgeon's interest related to splenomegaly as a mass abdomen.
Hello, sir.
Yeah, please.
Sir, will spleen enlargement, will it be always towards the RAF, right leg fossa, or can there be exceptions, sir?
See, every law has got an exception. By and large, spleen enlarges in that direction. But there is a condition called as visceraptosis, sudden loss of weight. So visceraptosis is a condition where spleen can be found in any quadrant, including there are reports where it is felt in the pelvis. So just to give an example to you, spleen can enlarge, but by and large, please always follow the rules rather than exception. Okay. spleen usually enlarges towards the, because it's the whole spleen is getting enlarged. It is not that one area of the spleen is forming a big nodule like thing. Any condition you look at that, no? Whether you talk about lymphoma, myeloid leukemia, proliferative disorders, in all condition, it is the entire spleen is getting enlarged, right? So
Right.
that may be the reason why you get the splenic enlargement towards the right left fossa. Yes.
Hello, sir.
Yes.
Sir, differences in character of pain in case of a massive splenomegaly and in perisplenitis.
What is the question you asked?
Sir, is there what are like differences in the characteristic of pain, which patient tells pain, sir, in case of a massive splenomegaly and in case of a perisplenitis?
Perisplenitis causes more of a diaphragmatic pain, no? So as when it is a diaphragmatic pain, obviously there should be more pain radiation to also the shoulder region. Whereas massive splenomegaly will not produce diaphragmatic pain. It is pain over the mass itself. Okay? Pain over the mass itself because of stretching of the capsule. All right?
Okay, sir.
Yeah.
Sir, we welcome Dr. Clement Rajan in the audience. Very nice to see you, sir, here.
Sir, good afternoon, sir. Good afternoon, sir.
Good afternoon, sir.
Good afternoon.
The splenitis pain is like pleurisy. The splenomegaly pain is a dragging pain.
Correct. Dull aching, dragging pain. Yes. So we will proceed to renal mass in the left hypochondrium. I have already mentioned this will be my next class on the lumbar region. But today I just brought this only one slide for you to know all the other questions which I will take. Ballotability, bimanual palpation next class. But this is just to keep you for the sake of completion. This is the list we have got here. When you have got a splenic mass, how to differentiate from the renal mass. I'll be putting this slide again, but just here highlighting the important point. However big the spleen undergo size, even the spleens are somewhere have come down to the left lumbar region also, but so difficult to feel them bimanual palpation, and ballotability is practically not possible. Other than that, you have got many common things, including the dullness, etc. So we'll discuss movement with the respiration, etc. We will discuss this in the next class. So these are the three important conditions again for surgeon's interest: renal cell carcinoma, hydronephrosis, and polycystic kidney. This is the three important diseases which we will discuss in the next class, right? So I will now go to the mass in the left hypochondrium. It is neither spleen nor kidney, but if it is something else, what else can come? As I mentioned to you, think anatomically, what other organ will come there? That's the tail of the pancreas. So as I mentioned to you first, somehow I'm not able to fit that into the spleen. Again, this moves with the respiration because it is attached to the spleen. But again, no notch is felt, and finger insinuation may be possible because it's not, the spleen is not enlarged. So you think that, oh, this is definitely not spleen, probably tail of the pancreas. So if you are suspecting, how do you suspect a mass arising from the tail of the pancreas? Number one, anatomical location, it is in the left hypochondrium. Number two, it moves with the respiration. But number three, it is a smooth surface and round borders. Finger insinuation may be possible, so that you know that it is not spleen. Patient might have had attack of acute pancreatitis. So pseudocyst not necessarily you can get from the body and the tail. You can also get them in the from the tail region. You can have a 5 to 6 centimeter pseudocyst just palpable in the left hypochondrium. They move the respiration. What is the management? Management is like any other way how you manage a pseudocyst. That's the way you manage. Last word is the key here, because one should not miss a cystic neoplasm arising from the pancreas may present as acute pancreatitis. So adding on more confusion, because these are the one cystadenomas. Last class when I discussed with you epigastric mass, I have mentioned to you female patients, a little bit of thick walled, larger size ones, they go for a cystadenoma of the pancreas, but usual location is little lower level compared to what it is. So, but nevertheless, if you are giving a diagnosis of pseudocyst of the tail of the pancreas, please also offer, sir, another cystic neoplasm I would like to consider, and that should be serous or mucus is a different thing. That's for a theoretical difference for you. Just a word of caution. Mucus is the one which gives rise to rather malignant potential. So one has to be more careful. So they can attain a large size. So the motility has been described as a tree-top mobility. I have discussed with you. So tail of the pancreas, 3 pathology you suspect for a surgeon. 1, pseudocyst of the pancreas. 2nd, cystadenoma. And the 3rd, carcinoma, tail of the pancreas. This is nothing but a carcinoma pancreas, but arising in the region of the tail of the pancreas. But remember, by the time it is palpable, it is sufficiently big, means, first of all, pancreas is a deep-seated structure, especially tail of the pancreas. By the time a mass from a carcinoma is palpable, invariably they would have gone to many, including orthopedicians, etc., for a backache, weight loss. By the time it is palpable, it has already infiltrated spleen, some cases colon, and some cases even a upper pole of the kidney. So carcinoma tail of the pancreas per se is a very poor prognosis because of the presentation itself is fairly advanced. Ultrasound and CT will give the diagnosis, and by the time patient has come with you, this is the feature. So tail of the pancreas anatomically can occur in the left hypochondrium. You have thought of 3 possibilities. When you have a tensely cystic swelling, think of a pseudocyst bar cystadenoma. When you have firm to hard irregular swelling, think of a carcinoma tail of the pancreas. And we have already mentioned to you one other possibility here which can come. Sorry, I think this is the same slide, sorry. It also exhibits with the movement with the respiration. As I mentioned to you, because the tail is attached there, it also moves with the respiration. And all features are confusing. This is my case only. A carcinoma arising from the tail, removed along with the spleen here, because it was infiltrating even the hilar structures. So from the tail of the pancreas, we have considered 3 possibilities when you have a mass in the left hypochondrium. If there is any questions related to up to now what we have discussed, pseudocyst of the pancreas, cystic neoplasms, and tail of the pancreas presenting as a mass in the left hypochondrium, I will take. Happy to see Dr. Ishwar Osmani, sir. Namaskara, sir. Yes, sir. Yeah. Any questions?
Sir, when the tail of the pancreas is involved in pseudocyst formation, sir, will there be involvement of spleen, sir? Intrasplenic pseudocysts?
Oh, there is, I see, don't ask all that kind of a, theoretical possibility. There's one entity called as what you said is correct. There's a possibility that you can have a cyst inside. There's another entity called as pseudocyst of the spleen itself. It is not related to the tail of the pancreas. It is a separate entity. So let us not worry about that. Okay. When you have a smooth, round swelling, almost moves with respiration, smooth surface, dull in color, think of a splenic. Sorry.
Thanks.
Sir, are you including adrenal mass in the renal mass section?
No, sir. Not today, sir. Not today.
That's clubbing with along with the renal mass.
Correct, sir. Correct, sir. Next, sir.
Okay.
Any questions? Okay. So, 4th anatomical organ I am thinking is the colon here. As all of you know, splenic flexure. Splenic flexure is the deepest part of the colon. Splenic flexure is the deepest part of the colon and easily missed at even laparotomy unless somebody does not carefully examine. So such growths are usually not palpable, I mentioned to you. But in our country, they come late to the hospital. Obstruction is the feature. They have got increasing constipation, obstruction. Mass is firm to hard. Most of the time with the restricted mobility, it moves with the respiration because of the contact with the spleen. But when it is fairly big, because of its irregular fixity, it also does not move with the respiration. So how to differentiate this? Little lower than the tail of the pancreas, and some amount of resonant note is possible. That is because after all it is colon, but if it is containing fecal matter, it's per se, obviously loaded colon, you will not be able to elicit that resonance at all. Colonic carcinoma, splenic flexure mass, you should not give as a diagnosis for a mass in the left hypochondrium unless patient has got features of intestinal obstruction, because they are usually constrictive lesions. When you think about anatomical structure, one has to consider colon also here, and so this is one of the differential diagnoses mentioned for a mass in the left hypochondrium. Obviously, it will be left going into little down, right? So again, short duration, irregular mass, most of the respiration, resonance, deep-seated mass, cecum may be distended, so that these are the points which will help you to give a diagnosis whether it could be colonic mass. This is to give an example to you. There's a loaded colon here. See here, it has come actually down here. This is not truly a flexure here, but just here you can see that's the area. So typically they are the constrictive lesions here, so which are causing a large bowel obstruction. So last anatomical organ which we are considering in the left hypochondrium is the retroperitoneal. I have told you sometimes that when you are given a mass in the left hypochondrium or wherever, it doesn't fit in with the upper GI pathology, it doesn't fit in with the lower GI pathology, it doesn't fit in with somewhere anywhere, you know, neither it is hepatobiliary nor, so then always consider a retroperitoneum, because once you say retroperitoneum, we have got a common, if you have got a young patient, think of a retroperitoneal cyst. Your patient is 20-year girl or 20-year boy who comes with the left hypochondric mass. When I say left hypochondric here, it is also going into epigastrium maybe, it also may be going to renal area. So if by the time they come with a fairly big size. All the tensely cystic masses will feel firm. They will have some amount of mobility. They move with the respiration because of the contact with the spleen. So young patient, smooth and round, think of a retroperitoneal cyst. Usually retroperitoneal cysts are lymphatic cyst. Depends upon the location. You may also have got a other type of cysts also. I mentioned to you sometimes a dermoid of the spleen also is mentioned. Hemangioma of the spleen has been mentioned. Retroperitoneal hemangiomas are mentioned. Now another thing is a same retroperitoneum, one patient almost like a spleen but quite a firm to hard in consistency, that can also be a retroperitoneal tumor. I have already told you these are the lesions which will not have the classical symptom of any system for that matter, any system. In that situation, usually you suspect a retroperitoneal sarcoma. I have discussed with this, I think, when I took the right iliac fossa or right hypochondrium, the management, etc. And then abdomen is, you know, like a Pandora's box, we say, no, rare, any surprises can come in this area. So now before I have one case presentation is there, for which I require one volunteer student to present. Till that time, now I will take any questions since another few faculty also are here. So to conclude, in a left hypochondric mass, we have a splenomegaly, kidney and adrenals. I have kept it little away today. We have tail of the pancreas, three possibilities. I told you: pseudocyst, cystadenoma, and of course carcinoma pancreas. From the colon, we would like to consider only one pathology. Then we have got retroperitoneum. from there you would like to consider 2 or 3 possibilities. So that is how you come to a conclusion, probably history, age of the patient, clinical examination, why spleen, why not kidney, why not colon, and you come to a diagnosis. So if you have any questions related to the specific, you can ask questions, please. Hello? Yes?
Hello, sir.
Yeah, please ask.
Sir, can you explain the movement with respiration part of the splenic flexure again?
Movement with the part of the splenic
Movement with
flexure.
respiration.
Yeah, as the name itself says, splenic flexure means it is in contact with the lower end of the spleen. You would have seen that now when you are mobilizing the spleen. So obviously when there's a growth, it's obviously it surrounds infiltrate the local tissue there. So when the patient takes a deep inspiration, you may be able to feel that in the left under the 10th rib. Okay.
Yes, sir.
The lenocolic ligament is attached to splenic flexure to the lower pole of the spleen. So that how the spleen moves from diaphragm, pushes the spleen down. Through the lenocolic ligament, the splenic flexure also moves. That's how it moves with respiration.
Yes.
The continuation of relation is there to the diaphragm through lenocolic ligament.
Just wanted to all of you to understand that students, especially right hepatic flexure, is a proliferative lesion. It becomes fairly big by the time they come, and there is again a colophrenic ligament, as sir has told just now. Easy, and it's very close to the liver. So whereas splenic flexure is quite deep, it's quite a deep structure, and it's a bend, acute bend there. So it should be a size should be sufficiently big. Then only that movement with the respiration can be appreciated. Okay. Yes.
Okay.
Yes. Any questions?
Rajan sir want to speak.
Sir, just a little point to help the PGs understand movement of respiration with respiration of the spleen. Now, the spleen lies in between the 9th and 11th ribs, and its long axis is in the line of the 10th rib. So whatever enlargements of the spleen occur, uniform enlargements of the spleen occur, it maintains the axis along the 10th rib. Now, if you follow a 10th rib after the costal margin, it comes to the umbilicus. You know that the umbilicus dermatome is T10 and moves down into the RIF. That is why spleens tend to move towards the RIF in the respiratory movements. It is due to the anatomical position of the spleen in relation to its long axis being parallel to and closely related to the long axis of the 10th rib, left 10th rib. So that explains the reason why it moves towards RIF rather than up and down with the respiratory movement. On the other hand, the liver directly is under the contact of the whole cupola of the diaphragm, and when the diaphragm comes down, the liver is brought down in a vertical direction towards the RIF.
Yes, sir. That's what I told them in the beginning, that common mistake done by the students is to say that I felt the spleen under the left costal margin. Actually, it is no. If you carefully watch, you should feel the spleen actually beneath the 10th rib, more laterally.
Yes.
So more laterally. That is the important thing.
A minimally palpable spleen is felt more laterally. It's only when the whole body of the spleen comes out under the costal margin, you see under the costal margin, and there you cannot insinuate your fingers under the between the costal margin and that body of the spleen. Very nice lecture, sir. I wish I had joined earlier. But, good one.
I want one student. Yeah, one student. Can you just read this? It's not at all difficult. Very easy. Don't worry. It's hello.
Hello, sir.
Anyone is ready?
Hello, sir.
Darshan, yes.
A 20-year-old lady with no previous medical history was admitted to the hospital with dull aching pain and mass in the left side of the abdomen of 20 days duration. She had one episode of vomiting containing food particles. She also had weight loss of 4 kg in the past 2 months. No history of fever, hematemesis, or bone pains.
So, if you try to analyze this history, we have discussed with you. Now, there is one 20-year-old lady. So, what does this tell you first? That's what I told you as PG. The first sentence itself should tell you something. You have to keep it in mind. Okay, start. What does it tell you?
Young age.
So younger age group. So that is the first thing you should know. Whether am I dealing with any congenital problems? Okay, possible or not possible. Little later we'll see. Now, what does it tell you? No history of fever, hematemesis, bone pain.
Cannot be lymphoma, CML.
Very good. Cannot be lymphoma. Cannot be CML. What else? Okay. History of hematemesis may be there or may not be there. Portal hypertension, can you rule out and say it is not possible? Hello?
No, the hematemesis is not mentioned in the episode of vomiting, sir.
That's what I just now told you. If there's hematemesis, is fine.
So we can't rule out. We can't rule out, sir.
If there is no hematemesis, it cannot rule out portal hypertension. Okay, it cannot rule out. Okay, yes.
Yes, sir.
What else? Other things you consider? Do you think it's colonic problem?
Weight loss of 4 kg is there.
In 2 months.
Yes.
You consider colon here for a 20-year girl?
Not the colon, sir.
So less likely.
Yes.
No?
Yes.
So if it is spleen, what are the 1 or 2 possibility you would like to consider? If it is spleen. Say no, portal hypertension.
So extrahepatic PVO, EHP.
Yes, definitely. I have already told you, hematemesis and melena need not be there to demonstrate to have a extrahepatic portal hypertension. There could have been some splenic dermoids, hemangioma, whatever it is. So other thing is pancreatitis, pancreatic tail is a dull aching pain. See here, dull aching pain. Is it hemolytic anemia? Can't rule out, but there's nowhere mentioned about history of jaundice, etc. Right? Yes. Okay, go ahead. Go ahead.
On inspection, a visible swelling was noticed in the left upper quadrant of the abdomen. On palpation, a mass of size 20 into 15 centimeter was felt in the left upper quadrant, occupying left hypochondrium, epigastrium, umbilical region, and left lumbar region.
So this was the finding in the case. It was not palatable, not bimanual palpable, and left upper abdomen. This is the mass. Look at this. So
since it's mentioned visible swelling, it can be the mass moved with respiration was firm. The mass moved with respiration was firm and upper border could not be felt since fingers could not be inserted below the left costal margin. No notch was felt. No pulsations were felt over the mass. The mass was not palatable, not bimanually palpable. Rest of the abdomen was normal.
So rest of the abdomen, when I say there was no hepatomegaly, there were no lymph nodes palpable anywhere. Oral cavity is normal. Neck is normal. No bony tenderness. So this is how the cases are given to you. Okay. Look at the size.
20 into 15.
So what are your possibilities coming to your mind at this stage? One is a retroperitoneal possibility. See, no notch was felt, correct. But you see, if it is felt, it's fine. If it is not felt, you again 100% you can't rule out. Okay, keep it in mind always. Spleen, right?
Yes, sir.
Because upper border
could not be felt.
So you are keeping in mind spleen. You are keeping in mind retroperitoneum. You are narrowed down to two important organs. Okay. All right. Can you read this CT scan?
It's spleen only.
No, can you just read? Yeah, no problem. Go ahead. Go ahead. You have to explain. No, you can't say in the MS exam it is spleen. What is the? Is it? What is it? Hypodense, hyperdense. What? Ecotexture. Septae are present. Necrosis is present. Surrounding area. Yes. Hello.
Hello, sir.
Yes.
So homogeneous enlargement. Homogeneous enlargement over the left
yes.
upper quadrant.
Now, as you see here, this is colon, no doubt. This is hardly any splenic tissue, and this is all the stomach and etc. here. Of course, we have only one picture. So this was our case. So what was the diagnosis offered in my college by 3 professors? Okay. The purpose of putting this case is, these are the real cases. The person who said pancreatic cystadenoma, he said because patient is a female, they are known to attain a large size. It moves with the respiration because it is in contact with the diaphragm, right? And when you have a very large size, the finger insinuation is not possible. Second professor said, no, it is 100%, he said it is spleen. He said, even though notch is not felt, I say it is spleen because patient is young age and such a large swelling. And third professor who said this gave a diagnosis of soft tissue sarcoma. The point which I am trying to tell is, in the university examination, it does not really matter what diagnosis you give to such a large swelling of 15 by 20 centimeter in the left hypochondrium, as long as you are able to explain size, shape, surface, border, consistency, mobility, fixity, plane of the swelling, all that you have done well. Because everything, it will not fit in with your diagnosis, right? So this was the picture which I gave you, and this is the lesion. After that, we thought it is the spleen, and I opened the case. In fact, the CT scan reported as it could be a splenomegaly. No features of portal hypertension in this patient. Endoscopy was normal, and we opened, and this is their finding of the, what I mentioned, a well-defined heterogeneous mass, left peritoneum, compressing the stomach anteriorly spleen. They thought it could be arising from the pancreas. They thought it's arising from the pancreas. Rajesh, welcome.
I've been listening, sir. Thank you, sir. I've been listening to your lecture.
I know you are there very soon. So there is this is the picture. There was professor who said cystadenoma, felt happy that my diagnosis is right. So people who said, this is the CT ultimate diagnosis. And I opened the case. The mass was so much big, encasing the splenic artery and the vein. And this was the spleen actually. And what was the diagnosis on table? Probably I thought could be some kind of a hemangiosarcoma, or could be some kind of a surprise tumor arising from the spleen, I thought, because this was a very, very nodular. Most of the area were hard here. Few areas were cystic. Young lady who has lost 4 kg weight. Now, the ultimate pathological diagnosis is reactive nodular fibrous pseudotumor arising from the retroperitoneum. Spleen and lymph nodes are free. I just want to bring your attention, for the sake of postgraduates, what are the lessons we have learned from the case. When you have a large splenic mass, it may move the respiration, but also think of pancreatic cystadenomas and retroperitoneum, especially some things were not fitting in. You were telling no, notch was not palpable. Always give 2 or 3 differentials which can explain most of the symptoms. And one thing you should remember, do not give a histological diagnosis unless you are really asked for it. Today you have seen this case. Don't give a histological diagnosis like this, and don't give a rare diagnosis, right? So just to keep you informed, the common diagnosis which is accepted in this was splenomegaly, second was cystadenoma of the pancreas, and third was retroperitoneal tumor, right? So with this, I'm going to stop my talk. If you have any other few questions, I am ready to answer. We have a good faculty list here. Yes, please ask.
So though it's retroperitoneum, still it is moving with respiration, sir.
That is what I told you. Look at here where it is in contact with. See here. So, pseudocyst also moves with the respiration if it is a large one in contact with the diaphragm. Okay. So, we have just now discussed with you, tail also moves. Look at that, how close it is to the spleen here. Okay. Right.
Okay.
So you should be able to explain in the examination why it moves with the respiration, because it is in contact with a certain organ. Right? Yes.
Can I come in, sir?
Sir.
Just remember, students, that this movement of respiration in the upper abdomen can be both ways. You can have movement of respiration in retroperitoneal structures due to their contact with structures that normally move with respiration. In this case, it was a large lesion related to the spleen, which was being pushed down, and they get the apparent movement with respiration on clinical examination. When you have lower abdominal masses and their plane is retroperitoneal, they are almost surely never moving with respiration. It should not even be mentioned. You cannot elicit movement at all. In the upper abdomen, it is 2 ways. If it is definitely not moving with respiration, the chances are that it is retroperitoneal. But if it does move with respiration, it can still be retroperitoneal because of its contact with diaphragmatic related movements of the with the respiration. So be careful. It's not dogmatic. It's not a fixed rule. It is a rule with more exceptions than being absolutely true.
That is the basic difference between the undergraduate and postgraduate, because you look at that seat itself should tell you. Somewhere it is maybe even in touch with the stomach here. Somewhere it is in the diaphragm. Somewhere here is the spleen. So all the reasons why such large, massive swellings in the upper abdomen will move with the respiration. Okay, right.
Dr. Rajgopal, what if the students say it is a gist with unknown actual origin? Can we accept that?
Sir, we have discussed the gist from the stomach and all in the last class, but such a large swelling which is in a 18-year girl with the smooth surface,
right.
Said the smooth surface, that is why we did not consider the gist. That's all.
Thank you. Thank you.
Yes. Prakash, sir, any comments, sir?
Sir, Rajgopal sir, can I add, sir?
Sir, Dr. Ishwar, sir.
Sir, when you were differentiating retroperitoneal from the intraperitoneal structure in such a scenario, the only clinical differentiating point is movement with the respiration. Whatever the retroperitoneal tumors, we have given explanation in contact with some other structures which are moving with respiration, we can say that. When the real scenario differentiating one from the other in a clinical diagnosis, when the student, are you expecting from the student in such cases retroperitoneal tumor moves with respiration? If that is the case, it doesn't have any other findings to say that to differentiate retroperitoneal from the intraperitoneal.
Sir,
do you agree with me, sir?
Sir, one or two things here, sir.
Yes, sir.
If this location is very important, if this were to be beneath the colon, there will be definitely small intestine loops which are anterior, which you get percussion, not a resonant.
Okay.
Now, this is especially hypochondrium area where there is no bowel which is coming anterior. So that is the reason why this difference, 1 point we cannot give. Otherwise, usually retroperitoneal tumors, when you percuss clearly, there will be a resonant no. Sure. Again, all these are not rules because it can push the bowel to the side. That is why I said 3 professors have given 3 different diagnoses.
So the specimen looking at this, still I feel it is a distal pancreatic tumor involving the splenic hilum.
No, sir.
I don't agree the retroperitoneal tumor because the way you have given the picture, it is going into the splenic tail. Only the tail of the pancreatic tumor, particularly solid or cystic pseudopapillary tumors in young middle-aged girl, invariably these are the findings. Invariably.
Yes, sir. That's why I said the last one is that Pandora box because of that.
I do agree, sir. I do agree.
Thank you. Yes.
Thank you very much, sir.
TV Prakash, sir, any comments?
Sir, I really am lucky to listen your talk. You spent continuously 1 hour 27 minutes non-stop talk. Really enjoyed your talk.
Thank you.
Few questions to postgraduates. What is the difference between wandering spleen and ectopic spleen? Usually asked in the examination, which is one of the questions. And really, I go with the one who has just now spoke, the faculty member. The student should not go from here and say examination, retroperitoneal swelling moves with respiration. That only thing comment.
No, sir. I think that
otherwise,
I think the point has been highlighted very clearly by our CS Rajan that this mass is in the hypochondrium, upper abdomen.
Yeah.
And it is in very close contact with one side, diaphragm, stomach, spleen, even for that matter, kidney, as it is becoming big. So obviously, it has got all the reasons for it to move with respiration. Yes, sir.
Yes. So thank you very much, Rajan sir and RK, especially,
thank you,
and Rajgopal Shenoy sir.
With this, I think I have to close the session, sir. We have to. Dr. Rajesh Balal will be coming in another 5 minutes' time. Thank you, Shenoy sir. It's always a pleasure listening to you. And then we can listen for hours together. Thank you so much.
Thank you, sir. Thank you, sir.
Thank you, RK. Thank you very much.
Thanks, everyone.
Thank you, Shenoy sir. Thank you very much.
Thank you, sir. Thank you.
Thank you, Radhakrishna. Thank you.